Hello, my name is Daisy Lay, and for my Unit 4 Sportsman 3 project, I am doing it on Rehab for reverse total shoulder replacement. So, some quick anatomy. The shoulder joint is made up of the upper arm bone, or the humerus, and then the shoulder blade, or the scapula. The rounded ball end of the upper arm bone or the humeral head moves inside a shallow socket in the shoulder blade. A reverse total shoulder replacement is a special type of shoulder surgery. During this surgery, a surgeon removes the damaged parts of the shoulder and replaces them with artificial parts. The difference between a reverse prosthesis and a standard shoulder replacement is that in a reverse prosthesis, a ball is placed on the socket side of the joint. This is the opposite of where it is naturally located, or the reverse of what you would expect. The socket is then placed on the arm side where it is supported by a metal stem. In a standard surgery, the metal ball attaches to the upper part of the humerus, and the new plastic socket attaches to the shoulder blade. This more closely follows a person's real anatomy. Most people get the standard total shoulder replacement. However, a reverse total shoulder replacement could work better for people with certain injuries, such as a rotator cuff injury, because in a standard surgery, you rely on the muscles and tendons around the shoulder joint to be intact. But in a reverse prosthesis, you can rely on the deltoid, so it is more ideal for people with rotator cuff injuries. So for the first 2 weeks or post-op, your main goals will be to minimize pain, minimize swelling, beginning passive range of motion exercises, and then educating the patient on some home exercises for the days that they are not in physical therapy. Straight out of surgery, you should wear your sling at all times except for during physical therapy or home exercises. For range of motion, we will be focusing on pendulum exercises and then forward flexion and external rotation. For forward flexion, we will be limiting it to 130 degrees, and then for external rotation, we will be limiting it to 25 degrees. We can also work on assisted elbow flexion and extension. For strengthening, we can start working on strengthening the periscapulary area and doing deltoid isometrics. We can also start doing some light wrist and hand exercises. For the 2 to 6 week mark, the goals remain about the same. We will still work on minimizing pain and continuing to improve passive range of motion, but then we will begin working on active assisted range of motion. The sling use remains the same. Wear it at all times except for during home exercises and physical therapy. And then for range of motion, we will continue working on passive range of motion, but we can now increase on the forward flexion to 140 degrees and then external rotation to 60 degrees. And we will now start working on abduction, and this is where we work the deltoid. And for all of these exercises, make sure you're advancing as the patient can tolerate. For active assisted, we will be doing forward flexion using pulleys or a cane, and we can do this up to 90 degrees. We we'll also work on elbow extension and flexion, just like before. And by this point, make sure the patient knows that they should not be doing any cross-body or internal rotation motions. For strengthening, we will work on periscapular strengthening exercises, similar to before, and then shoulder submaximal isometrics. Continue doing wrist and hand exercises, and then you can add light resistance if it's appropriate for your patient. For the 6 to 12 week mark, continue advancing in passive range of motion, begin active range of motion, and then begin light shoulder resistance exercises. By this point, your patient should no longer be in a sling. Progress passive range of motion as tolerated for your patient, and then begin internal rotation and cross-body motion at this point. Begin active range of motion exercises in all directions, so flexion, extension, external rotation, and internal rotation, and progress as tolerated for internal rotation, so it is not excessive and causing your patient pain. For strengthening, continue isometric contractions in all directions and begin light resistive exercises. You can now begin TheraBand exercises to increase forward flexion, extension, and external rotation strength. You should limit internal rotation strengthening at this point. And then for 12 weeks and beyond, work on advancing to the end range of passive and active range of motion. Restore normal scapulothoracic rhythm and motion. Advance muscular strength, and then transition your therapy to a home exercise routine for the patient. Same as before, no more sling. For range of motion, progress to full passive range of motion and active range of motion. And then teach the patient flexibility exercises to continue at home to encourage full range of motion. For strengthening, you should increase resistive exercises and include weights and resistance band. Same as before, you should progress everything as the patient can tolerate. By this point, you can start moving on to day-to-day motions that the patient will need, and then some sport-specific activities. All right, thank you for watching.